Thank you very much.
Thank you very much, Lee, and thank you to all our contributors to this webinar this afternoon. There's been comments rather than questions in the chat. So has anybody got any questions for any of our speakers? Just raise your hand. So we've got Abigail Sifa. It would be quite useful if you could actually just introduce yourself and who you are before you preface your question, and thanks very much. Over to you, Abigail.
Sure. Hello. So I am a Macmillan Primary Care Cancer Lead Nurse in Eastern North Herts, and my role looks into providing training for the cancer care reviews and also how we can reduce health inequalities. I want to say, first of all, thank you so much for sharing. Thank you to all the patients that shared as well. I think it's brilliant having virtual consultations. My only question and / concern is having it sort of in like a group for people who, you know, may face health inequalities or maybe don't have English as their first language. I just wonder whether there's been any consideration into how we can continue to further engage them, or whether, you know, they might find it difficult to be open about some of the issues that they face. And, you know, I think some of the problems that patients do face post-treatment, it might be, you know, sexual issues or issues with their bowel function and things like that. And I just wonder whether having it, you know, as a group, whether it might hinder patients for being as open as they would have if it was just one-to-one. Thank you.
Who would like to pick that up on a very Fiona, if you could pick that up.
If you don't mind. Hi, Abigail. I'm glad you're here. Really glad you're here. I think this is an issue. I thought it was an issue all along. In fact, I was invited onto this project because I was so skeptical about the idea of a group consultation. But I think the arguments for doing this are reasonably persuasive in the sort of, when you look and research where group consultations have happened. So, but I think it's really, really important that we give people the choice. And also, I think, explicitly give them the choice to say, why don't you come and give it a crack? And if it doesn't work for you, if there are things you just can't talk about in a group that you need to raise, that you get the option of a follow-up or to opt back into a face-to-face one-to-one. So it doesn't have to be face-to-face, but a one-to-one consultation. I think we need to be really clear that people have got a choice about that. Because the other skeptical thing I said was, you know, I don't, so it's difficult for me because I've got a urological cancer, but the principal effects I'm living with are from Whipple's and upper GI issues. So, you know, I don't know if a urological discussion is going to be very useful to me. And I'm arrogant and self-centered, and I don't know how much I want to listen to other people bleat about their concerns because I'm a selfish cow. But, you know, I think I can really, really appreciate that people are going to say, well, actually, I had that and I found this useful, or yeah, that drives me mad too, but this helped. You know, I think there's huge, huge scope for this. And we know that people might come to this a little bit, well, both skeptical, worried, a bit nervous, but that the chances are that with the right input and the right encouragement, that actually they'll probably find it quite useful. I think the get out card is really, really crucial.
Okay, Ginny, you put your hand up. Was this to separate it, was this to comment on this issue?
It was to comment on this issue, Peter. So first, I just want to say, although Fiona said much probably in a different way of what I would have said, my hackles went up straight away, Abigail, because this is twofold. So because what you said is a common reaction that, ooh, you know, what about this being in a group? But actually, then when you clarified it and you particularly picked out kind of cultural differences, and then I came down a few notches, because actually that's a really valid point, and I think that needs some consideration, that there will be certain cultures and subsets of people that maybe find this uncomfortable. But those aside, and what Fiona has come around to thinking is that from my experience, I was a nurse for many years, and we used to do health and wellbeing events and bring prostate patients together and bring gynae patients together. And actually those quiet patients that wouldn't go to a GP, or probably there's no time in a GP cancer care review, even if they get one, wouldn't bring up the fact that they've got concerns about erectile function, or the cervical patients with gynae issues, with sexual issues. But actually when you get that brave patient that's part of that group, and there's often one outspoken patient that will, as Fiona said, put their hand up and put it right out there, that encourages those other patients to get that information. And I've seen that, and I've seen how well it works, and that's my passion behind this programme.
Okay, Liz?
Yes, thanks, Fiona and Abigail. And I think two things. You're absolutely right. But it's, of course, it's managing expectations. It's getting the information to the patient before they're given their virtual group cancer care review, so that they do understand, and whether that's a conversation, and ideally, you know, at that 3-month quaff thing, when we say you've got your diagnosis, this is what we will be offering you if you want. So we already manage that so that people can opt in or opt out. And the model that we've got, not only is there going to be a nurse, but there'll be a facilitator in that room as well, so that if there is a difficulty, people can leave at that moment. They can go out to one of those clever IT breakout rooms or whatever they do. I don't know how that works, but there's going to be training for that. I might join it. But I think you're absolutely right. And I suppose it comes back down to this thing that one size doesn't fit all. And really good, Abigail, because this is the part of the evaluation, isn't it? We will need to change and evolve and improve as we go on.
Lee, did you want to have the
Yeah, that was exactly what I was going to come in with. Obviously, we know we can sit and try and hammer out a perfect system, or we can sit and hammer out something that we think is a good starting point. And this is where the evaluation comes in, because as I've said, the evaluation is iterative. We are taking initial feedback from that evaluation to start to shape future sessions. So hopefully, if we are coming across the right people, that will also contribute to our understanding. And we can do much more in that evaluation work going forwards in terms of reaching our diverse populations.
I mean, I think most people have said the points I would wish to make. Well, one, we perhaps haven't made clear enough that participation in the virtual groups is not compulsory. It's patient choice. If patients don't want to get involved, they don't feel it's right for them, that's they would have a conventional cancer care review. I think it is fair to say, and thank you for bringing it to our attention, that we haven't addressed the diversity agenda in the design of the project as much as we should have done. But I think that's hopefully something that we can address as the pilot progresses. We look at the demographics of the individual practices and make sure that we have a representative makeup. And we would like to think that virtual group consultations will actually help to address inequality, because it avoids health transport issues. There's communication problems doing conventional cancer care reviews. And I think I was going to wrap up by saying that we do not think this project is going to solve all the problems of looking after cancer patients long term, but we're starting out from a pretty low bar. And Fiona's slide demonstrated that more than anything. We know, Liz and I know, that doing the sort of medicalized cancer care review, that is all we do at the moment, doesn't even begin to address any of these concerns. And hopefully the model that we will develop is not going to solve it. And we hope indeed that it'll actually raise more questions than answers. Is there any other questions that anyone points like to raise? I think there was a lot of comments in the chat about people's good experience in the areas where they work, which is all great to see. Sorry, Lisa Benson, got a question?
Yeah, hi, just one quick question. I've got we have 2 nurses here that have done the cancer care review course, but we've also got a new practice nurse who may well be very interested in taking part in this. But is the training for the virtual adequate for that, or does she also need to do some cancer care review formal training?
Lisa, do you want to pick that up?
It should be adequate, Lisa, because that's the reason we were keen on having this company. They scored highly because they have such a clinical background, palliative care, primary care, etc. So this is something that we can explore as we develop the programme, because we've also incorporated co-design into this. So this is where having feedback will be really useful.
Okay, that's lovely, thank you. I've got one other question. I've had a few patients of late discussing various things that I can't answer. One, unhappy that they hadn't seen anyone face to face at the secondary care. Quite a few people that don't know whether they should or shouldn't be having flu and COVID, and a few other various things that we can't answer those. But I just wondered whether it would be possible that maybe secondary care and primary care could sort of have a newsletter with sort of some of those commonly asked questions that we might be able to just go to. So for those that are coming in for flu and COVID vaccines, I don't know what their consultant may or may not want them to do. But if there was a common thread that we could go to that newsletter and it says, by the way, this is what we're doing at the moment, or that it would be quite helpful. And I'm a bit concerned that if we're faced with 8 patients on a screen, that they're the sorts of questions that are just technical questions that we can't answer. And it's very easy to manage it at one-to-one, but when they've got a screen of people saying, yes, and that's what's happened to me, and I haven't heard, I just wonder if those common questions might be easily answered on a newsletter or something. I know that's more work for secondary care and primary care, but I don't know, it would be very helpful.
I think that's an outstanding idea, and I'm sure that's one of the things as we run the pilots, if common themes, common questions arise, that in itself will be worthwhile, and we can certainly begin to compile a FAQ document or something of that sort to address those kind of issues that crop up commonly from the pilot consultations.
Lovely. All right.
Liz?
Thank you.
Yeah, I was just going to say, because obviously Lisa and Sarah sitting there were part of the Whitley team that I was lucky enough to be part of myself. And I am absolutely confident that with Lisa and Sarah's mentorship, that the new appointed nurse will have no problems at all with this cancer care review. And the other thing, I think it's a great idea about the newsletter, but just to say we are lucky in MSE, we have got a new person in post who's just started, Katie Lowe. She's an integrated cancer care lead nurse. And her whole remit really is to be linking primary and secondary care. So, you know, that go-to person rather than I don't know, you try and speak to a medical secretary in the trust, etc. We are out to advert for 4 facilitators in the 4 alliances in Mid and South Essex who will be working with each. So there'll be one for Mid Essex. So there will be better lines of communication, Lisa. But great idea about the newsletter. We just need to keep it up to date, because the trouble is, you know, requirements change and rules change, but great idea. I'll take that back to the rest.
Lovely, thank you.
Thanks both. I'm afraid we're a bit over time, so I am going to wrap up. So thank you very much, everybody, for attending. And I think I think I'd like to say that I mentioned we're starting from a fairly low bar. I think we are. Charlotte mentioned the National Patient Experience Survey. Primary care fares very poorly, mainly for stuff pre-diagnosis and post-diagnosis. And there's often talked about in primary care circles about, oh, we've got this fantastic experience about managing long-term conditions like diabetes and ischemic heart disease. So we'll just apply that knowledge to living with and beyond cancer and everything will be fine. And I think even in the work we've done shows that we actually haven't got the first clue. And if we can begin to add to that begin to get a few more clues at least, then this project will have been worthwhile in its own right. So thank everybody for coming this afternoon, and we really look forward to reporting in the near future about how things are going.